We actually started with IVF right off the bat. My husband was super open with me about the fact that we would face infertility challenges from the beginning, but I don't think either of us realized how challenging it would actually be.
Whether it comes out of nowhere or if it's already been predetermined, needing help to have a baby can be a significant challenge. Over the years, we spoke with many who never thought they'd need intervention, and we've spoken to a few who knew they'd need help too. But knowing or not knowing that fertility treatment will be needed is only part of the story. While success rates are high and getting higher, there's really no certainty that any given treatment will work the first time or the second time, etc. Today, we'll hear from Lizzy, who will walk us through the turns of their journey. I'm Dan Bulger with Progyny, and this is Infertility. Hi, everyone. Thanks for joining us today. I was recently told that I don't do a good enough job asking for ratings or reviews. So, well, if you have a chance, please leave a rating and review. They really help. Today's episode is a bit of a special one in that we're not only hearing from Lizzy, but we also brought in a doctor to help shed some light on a specific part of this story. And that will have to do with the diagnosis that Lizzy's husband had prior to the couple even ever trying to have a baby. And we're going to get there soon, but first, let's get to know Lizzy.
I'm Lizzy. I'm living in Seattle, Washington, and I'm a program manager at Facebook.
I don't know if you've noticed this really, but I have yet to say Lizzy's last name. I'm just going to come right out and say it. I have a hard time pronouncing it correctly, and I really don't like to say people's names wrong, especially when making a podcast about a significant moment in their lives. Maybe that makes me a coward. I don't know. But here's Lizzy to help us all out.
To be honest, it's French, so it's Colas. But you can say Colas, you can say the Colas family, you can say Colases. We'll respond.
All right, I'm going to try. So Lizzy Colas and her husband did want to have a baby. And as we teased at the beginning, they knew going in that they would be needing help. I'll play it again in case you were just getting settled in when we started.
We actually started with IVF right off the bat. My husband was super open with me about the fact that we would face infertility challenges from the beginning. So we always knew that we would need medical intervention, but I don't think either of us realized how challenging it would actually be.
Okay, so what is this all about? Was her husband just a super IVF fan? Well, no. He was born without a vas deferens. And this brings us to our second special guest of the episode, Dr. Joseph Alukal from Columbia University Irving Medical Center. And I have to say, this was a great booking by Selena, Shannon, and team, as he is absolutely the right person to talk to about this, because Dr. Alukal is a reproductive urologist. When we're talking about IVF, and when we're casually saying the term fertility doctor, we're almost always talking about a reproductive endocrinologist, or REI. REIs are experts when it comes to female human reproduction. But of course, human reproduction includes another element that's excluded from that description. You guessed it, sperm. And when there's a male partner involved and a male factor infertility indicated, well, you need to bring in the male fertility expert, a reproductive urologist. Admittedly, that was a pretty narrow description of the role of an RU, so let's let the expert step in. What's the role of the reproductive urologist?
Certainly. So the patient who is seeing me in my clinic for fertility concerns, generally speaking, is a male patient, a patient who makes sperm, and they are either pursuing fertility care or they are curious or interested in knowing about their fertility potential. And so that involves typically us answering that question through a semen analysis, most importantly, a physical exam, some laboratory evaluations. And then we have to take what we find and put that in the context of that patient's partner and whatever fertility treatments they're pursuing based on their partner's evaluation.
Now we're talking. So let's dive into this thing. What is a vas deferens?
So the vas deferens is a tube that colloquially people are going to know best because it's what gets sniffed when a person has a vasectomy. Okay, so that usually gets patients understanding what are we talking about it carries sperm from the testicles, and of course there's one testicle on each side and one of these tubes, one vasa on each side, carries sperm from the testicles deep into the pelvis to the base of the penis and the prostate. And that's where it gets mixed in with the remaining fluid that then constitutes semen. Okay, so this is an important distinction. Like, people will get confused about this, ask questions about this all the time. Well, doctor, how can you tell me that I have no sperm? I've got fluid coming out, and I need people to understand that fluid is semen, and there may very well not be any sperm in it, and we only find that out by examining that fluid under a microscope. Now, again, imagine a guy who's come in to see you because he wants a vasectomy. He tells you, I have been in a relationship for years. My partner and I have 3 children who we conceive very easily. We don't want to have any more children, but we'd like to be able to have unprotected sexual intercourse. The procedure you do on that guy is to identify that tube, again, one of them on each side, and to snip it, as people joke about, as is known in the general public. And by snipping that tube, you prevent sperm from the testicles from making it all the way downstream and into the patient's semen. And as a result of that, if you give the patient enough time after he recovers from the procedure, he won't be able to father a pregnancy anymore naturally. Okay, he continues to make sperm, but they have nowhere to go. And when he ejaculates semen, there's no sperm inside of it. So now instead, imagine a patient who was born without that tubing. And I think people, when they have this condition, they tend to be surprised that it's fairly common. It seems to them like something where they're like, why would that have happened to me? Isn't this like a one in many million sort of event? And actually it's not, because the most common medical condition that this is associated with is cystic fibrosis or cystic fibrosis mutation carriers. And so that's a condition that people know about. It's a complicated disease that can, in some people, cause problems with their lungs. It can cause, in some people, problems with their pancreas. But it's a genetic condition inherited from someone's family members. And in certain populations, the genetic abnormalities or mutations that are associated with that condition are really pretty common. So it's 1 out of 20 people, for example, in a population of Scandinavians who are mutation carriers for this particular condition. And if you're a male patient and you have 2 mutations of this gene, you may have, to varying degrees, what people might say is quote unquote cystic fibrosis, or maybe you've only got a little bit of problems on that front, and maybe the doctor never even figures out that you've got that issue. But you're pretty guaranteed to be missing both your vas deferens. And so sometimes I'm the person who figures out that this is what is going on in the patient. The patient comes to see me. He's already checked the semen analysis. It showed no sperm. He and his partner are really worried. And when I examine him, I tell him, oh man, I know why you're like this. You're missing this tube. Now, the next question, of course, is what are we going to do about it? But alongside that, I need to send him for some genetic testing to see if he has the mutation that I'm talking about.
Now, that might not have gone where you expected. We started out talking about the lack of a vas deferens, and then the next thing you know, we're talking about cystic fibrosis. And that's kind of an interesting point. Sometimes when men go to get evaluated for fertility, an underlying condition is found. And this can be a huge deal that can really change or even save the man's life. Now, before I say another word, I want to be very clear. Dr. Alukal was not the doctor that diagnosed this patient. And we're not saying that Lizzy's husband has cystic fibrosis. Lack of a vas deferens doesn't mean cystic fibrosis. But we brought it up because it's very important for men to understand that getting evaluated for fertility is not only a good way to, be evaluated for fertility, but it's also a potentially life-changing decision. If there's male factor infertility present, there might be something else going on. So go get checked. Underlying conditions and issues aside, the problem was the problem. There was no vas deferens, and that meant no sperm present in the semen. Now that sounds like a pretty tough thing to overcome, but fortunately, it's certainly doable.
Couples can be really disheartened to find out that the male partner doesn't have any sperm in his semen analysis. But I try to be encouraging to these people because almost always there are numerous sperm to be found. They just have to be taken out of the testicle with surgery. So they're there, and that's, in my mind, a good situation to be in, as opposed to some patients where we don't know if there's sperm to be found in the testicle, and they also have a a zero sperm count. And so because those sperm are there and easily found, we can actually do less invasive procedures to try and find sperm for the reproductive endocrinologist to work with. Sometimes those procedures can be as quick and easily accomplished as a couple of needle sticks to numb the patient up in the office, and then a third needle stick to actually take sperm out of the testis. And many times there are many sperm there to be used. And the reproductive endocrinologist tells us, yeah, we had a great result today. We've got great fertilization, a bunch of healthy embryos, and we put the excess sperm in the freezer. So hopefully when that works like that, the patient only needs to have this procedure once, and that should be enough for all of his family building going forward.
So no sperm in the semen is not necessarily the end of the road, which is fantastic news. And once the sperm is extracted, fertility treatment can then move forward. But the options are narrowed to one: IVF.
IVF is the only way forward. IUI is not an option. Many years ago, when first, the particular kind of IVF that we do for men with severe male factor infertility, which is called ICSI, intracytoplasmic sperm injection, when that didn't exist, so now we're talking before the early 90s, or when IVF didn't exist, now we're talking before 1980, people did attempt in these patients to take sperm out from the structure next to the testicle, the epididymis, and see whether or not they could do artificial insemination or standard IVF with it. And the success rates were abysmal, like so low that I can't, even if a patient tells me they want to try and do that, I tell them it's just not good medical advice for me to tell you to try this. There really is such a small chance that it would work for you guys. So what I think people need to plan on having happen is they'll do an IVF cycle where a technician does ICSI, takes individual sperm and inserts them, injects them into an egg one at a time. And so with that, the success rates are really high. And so that's why I think people need to be counseled, hey, we're going to do the right thing for you guys as a couple. Hopefully this is sort of a one-shot deal where after we do this particular kind of IVF, you guys are going to have plenty of healthy embryos, and that's going to be that.
So while Dr. Alukal mentioned, yeah, technically you could try IUI this way, it's extremely not recommended as it's very, very unlikely to work. So IVF with ICSI is really the way to go. Which brings us back to the Colases. I decided to say it the way she told me I could say it. When they wanted to start trying, they knew it was going to be IVF.
Basically found a clinic that was really close to my office, and that was how we chose our first clinic, which we later found out is not how you choose a clinic.
If only we could do an episode on how to choose a fertility clinic. Just kidding. Of course we did. It's episode 125, Fertility 101, How to Choose a Fertility Clinic. Go check it out.
We did 3 egg retrievals with that clinic, and we got 1 embryo of fair quality. So at that point, they basically told us we couldn't have kids.
3 egg retrievals and only 1 embryo. Not only is that very physically and emotionally exhausting, mentally frustrating, but it's also very expensive.
We had coverage under my employer, and their benefit was that they covered $15,000 for infertility, which was a max lifetime value. And after that, we had to pay out of pocket. So those $15,000 basically covered the medications for 1 egg retrieval.
Lizzy is now at Meta, formerly called Facebook, and they offer some incredible benefits, which we will get into. But at that time, her coverage wasn't really sufficient, and so they were paying a lot of money per cycle. And this process was a bit baffling for the couple as well. See, it's not that the egg retrievals weren't getting many eggs. Quite the contrary, actually.
We ended up getting like 50 eggs per egg retrieval. So we were very successful with the egg retrievals, but by the time we got to, each stage where they call you and give you the updated numbers, every single time it would be cut in half. And then by the time we got to genetic testing our embryos, we'd usually have 2 left. And usually those would, they would call us and they would say neither of them were genetically viable. That was pretty typical. So by the time, second or third time that happened to us, we were just so at such a low point. It was pretty devastating.
Attrition throughout the process is to be expected. Going from, say, 20 eggs down to 3 or 4 chromosomally normal embryos is fully expected. But this was a bit extreme. So this was all very hard on the couple, and making matters worse was that at the beginning, they were doing this in relative isolation.
I remember actually the first year that we were doing IVF, we kept it completely private. We didn't tell anyone about it, not even our families. And after the first year and after we had gone through this once or twice, we realized that it was just too much of a burden to bear on our own. So we came out about it on Facebook, and I remember just writing the post and sitting on it for about 5 minutes before I actually posted our story. And then I clicked post, and I didn't check Facebook for a while. And then my husband was like reading it and came to me and said, "Oh my goodness, you cannot imagine the most amazing things people are posting, or commenting, I should say." So we got so much support from our friends and family through that. And it was just such a surprise. I think especially because IVF is so controversial, I wasn't sure what people were going to say to us, but we just couldn't bear the burden on our own anymore. So through that process and just being so open about it, we were able to find a wonderful support network through our friends and our families, and also our colleagues once we came out about it at work as well. And I also have a wonderful therapist.
Not only were they finding support, they also found that many people in their lives, some they knew well, others from the past, experienced infertility as well. It's a powerful thing. We all need to make our own decisions on when and how to disclose personal things that we're facing in our lives. But it's important to know that frequently when we do, we only come to find that we're not the only ones going through something like this. The results weren't where they wanted them to be, but they weren't ready to give up. And the first thing they knew they needed to do was to find a different fertility clinic. So yes, in this instance, it was a great idea to change clinics.
We switched clinics for 2 reasons. One was because my husband got a job at Facebook, which uses Progyny for infertility benefits. The clinic we were using at the time was not covered under Progyny, which ended up being a good thing. Also, I got 2 second medical opinions through my previous employer, and both of the specialists recommended that we leave our clinic. And we also did some research and found the SART data, which led us to choose our current clinic over the other clinics.
Yeah, quick word about the Progyny network here, as I know that the team, Sam, Paul, Michelle, Raya, Janelle, and the entire network team here at Progyny work very hard to make sure we work with the best doctors, and they'll appreciate me adding this little layer of context for you. The Progyny network is expansive. It truly is. So we work with a lot of doctors and clinics. But here's the thing. We don't work with all doctors and clinics. And that's not because we can't. We certainly could add plenty more to our network, but that would be a disservice to our members. Without picking on any one specific clinic, it's just important to know that all clinics, and critically all labs, aren't the same. Quality differs depending where you go, and Progyny only partners with doctors and clinics that reach our standards of care. If you are at a Progyny clinic, then you can be confident that you're at a modern clinic that's practicing today's best practices. So whether you have the benefit or not, you can take advantage of this fact by using our Find a Provider tool at progyny.com/findaprovider. So when Lizzy found out that her doctor wasn't in network, well, as she said, that was actually a blessing. It led to more research where she discovered that this clinic was below average in stats and was not recommended upon review.
I think the fact that Progyny has clearly done their due diligence on who should be in their network and who shouldn't be was a huge win for us, because we had done our research wrong, I would say. So getting the guidance, so to speak, from who was covered under Progyny was a really great thing in the end.
Now, all of that being said, changing fertility clinics can come with some hurdles.
When we actually switched clinics, we had that one embryo of fair quality, and we literally took it in the car with us in a nitrogen tank and drove it from one clinic to the other, which was wild. And then since then, we've been super happy with our clinic. We've had 6 embryo transfers with them, one of which resulted in our daughter. And the clinic is just amazing. The doctors, the embryologists, the nurses, and even the front desk staff just celebrate us with us when things go well, and cry with us when things don't go well. They're like family to us. So I think we made the right decision.
Lizzy kind of spilled the tea there a little bit, but here's how the next cycle went down.
We had a similar result in terms of eggs. So we had like 50 eggs or something like that. And then I think about 15 genetically viable embryos. Maybe it was 12, something like that. I don't remember the exact numbers. But we were much more successful. I think, they changed up the hormones a little bit in terms of dosing, took me off some medications. It was a much less sort of lab rat kind of experience than I had previously had. So I think they were a lot more humane in their treatment, and it just felt like a better experience, and it was more successful as well.
They had so many viable embryos that she lost count. That's a significant difference. And I wasn't there. I can't tell you exactly what the previous clinic was doing and how that was directly impacting things. I have no idea. But the data between the clinics was clear, and when you follow the data and today's best practices, you are just so much more likely to find success.
I would say definitely look at the SART data. And I would also say to have a conversation with the doctors before you go, and just make sure you get a good feeling from them and that you feel like you can trust them, that you feel like you're getting the explanations that you need, and that they're going to be your partner and work with you through this entire process, because you're going to see them a lot, and you want to feel like a human as much as you can throughout this entire process. And you also want to make sure that they are staying up to date on the latest research.
The journey wasn't over yet, but having many embryos in storage meant that the level of hope was considerably higher.
But yes, we did have 4 miscarriages, which is an incredibly difficult experience to go through every single time. And each one is so different. You would think that going through miscarriage that many times, you'd get used to it and you'd know how to cope with it. But each one is just so different from the next. You just have a couple strategies, but there's never a straightforward or easy way to get through the emotional process. I was able to remain optimistic for every transfer, surprisingly. But I think for me, for every transfer, part of that process is getting myself into the right mental state and emotional state, and just being optimistic and trying to give each embryo the best chance it can have. So I wouldn't go into a transfer unless I was fully ready, mentally, physically, and emotionally for that.
There's a lot to unpack in this episode. Male infertility, recurrent pregnancy loss. They went through a lot of treatments over this period of time. And as we mentioned earlier, these aren't inexpensive procedures. But as we also mentioned earlier, the couple changed clinics when they got the Progyny benefit, which was a significant turning point in their journey.
Oh my goodness. It was like Christmas, but better. I remember the conversation specifically because my husband was being offered a position at Facebook, and we were trying to understand the compensation package. And so we literally got on the phone with a representative from Progyny and tried to find the catch in the coverage. Like, where were we going to be paying a ton of money for this infertility treatment? And we kept asking, is it the meds that aren't covered? What about the egg retrieval? What about the transfer? What about the genetic testing? What about this and that? And she kept saying, no, that's covered, that's covered, that's covered. And we were just like, this is unreal. So that was just amazing. It's been life-changing.
They were put through the ringer, but the end result was a happy one. After all the cycles, all the letdown, all the pain and frustration, after all the years of trying with fertility treatment, they finally met their baby. I want to thank Lizzy for joining us today, and I also want to thank Dr. Joseph Alukal from Columbia University Irving Medical Center for bringing his expertise. And I want to thank you for listening. If you enjoy this show, please don't hesitate to leave a rating and review. They really make a big difference. You can follow This Is Infertility on Instagram at This Is Infertility Podcast, and you can follow Progyny on Instagram at Progyny Inc. This Is Infertility is brought to you by Progyny. Please remember, this podcast is not intended to substitute for the personalized expert advice of your physician. I'm Dan Bulger, and this is Infertility.